and beta HCG pregnancy related. And WBC to check the infection in order to rule out that PID. Okay? Sometimes patient may come with tube-ovarian mass, tube-ovarian abscess, TOA, tube-ovarian abscess. Patient will have severe illness, high rise of temperature, nausea, vomiting, anorexia, anemic, WBC count is very high, pain, serious pain in the lower abdomen, okay? Then alpha fetoprotein, AFP, then carcino antigen 125, it is a marker for the cancer, especially in the female reproductive organs, the ovarian, and another one is carcinoembryonic antigen. So these are the three available and the common blood markers that might be in consideration to rule out is there any cancer related pathology is in the lower abdomen. Another marker you can know it, that is called BRCA1, BRCA2, breast carcinoma antigen, breast carcinoma 1, breast carcinoma BRCA2, because there are some suppressors gene in order to prevent the cancer in the breast and the ovary. And if there is a mutation on that suppressor gene, so then cancer chance in the ovary and in the breast is more. Okay, and it runs in the family. That's why those who have a family history, so they need to go for BRCA gene 1 and gene 2 to see is there any mutation or not. Okay, so these are the lab values, and along with that you can do some urine test. Okay, let me write down here BRCA gene 1 and 2. Okay, 1 and 2. And we can do the urine analysis. Why we need to do urine analysis? We need to do urine analysis to rule out is there any UTI, cystitis, UTI, okay, pyelonephritis. Yes, we need to check it out. Okay, so that's all for the lab values. And let's move on to the diagnostic procedure. Okay, what are the diagnostic procedure? Okay, so I'm taking off this part so that I need to discuss, I need to draw some diagram for these diagnostic procedures. Okay, I'm taking off this part and this part. Okay, that was my heading. Okay. Now, diagnostic procedure. What do you mean by diagnostic procedure? That means what are the other modalities? What are the other examinations we might to do, we need to do on the patient based on the history, physical examination, and the lab values that we need to do. Why? Our ultimate goal is to get the diagnosis. To get the diagnosis. Okay, so now let's talk about the pap smear. The pap smear, you know that during the fertility age, here we consider from age 15 to 45, or now they said until your menopause. Okay, until your menopause, they go for pap smear. Okay, in this pap smear, what they do, they take the cells from the tip of the cervix, because cervical cancer is one of the leading cause, so far I remember, is the 5th leading cause of death in this country, and 5th leading cause of death in women in this country. And the cervical cancer, ovarian cancer, and the pancreas cancer, usually they are not diagnosed in the earlier stages. Patient feel like, oh, those are the vague complaint, I didn't have anything wrong, okay, I'm fine. But whatever it is happening, I know I am a woman, I have a lot of other organs inside there, maybe that is the cause, something wrong with that. But they never think about that malignancies. When it is diagnosed, oh my God, it is already in the stage 3 or 4. And surgery is not possible, radiation is not possible, only chemotherapy. And the chemotherapy is not a good method of management, okay? That is tough. Not everybody is good for the chemotherapy. So, pap smear. In the pap smear, what they do, how they get the tissue, there is an instrument, okay? But make sure, sonographer, you're not going to do that. Somebody else will do. Okay? There's an instrument with the patient's consent, with the patient instructions and informations, means explaining the procedures. Okay? Patient will be appointed, definitely. And in the exam room, doctor will insert the, we call it gooseneck, the instrument inside the vaginal canal and open it. And they can see from outside the tip of the cervix. During the observation of the cervix, they like to see what is the color of the cervix. Is there any bleeding? Is there any lumpy, bumpy? Is there any necrotic area? Is there any collections? Okay, so then they will insert the cotton tips, cotton stick, and that comes in a concealed tube. They will open, they will take off the tips of the cotton stick, and they will insert into the vagina, and they will make a touch on the cervix, and they will take the smears from the cervix and they will take it out, and they make slide with the tissue, and they dry up, and the cytologist usually they will examine what type of cells from the cervix are obtained. Okay, it is very easy. First time it is little anxiousness, but the consequent time and the subsequent time it is not dangerous. Okay, but make sure 15 years, 16 years, patient may not have rupture of the hymen. Patient never had biological activities. If patient says, no, I never had this problem, but I don't want that. Okay, most of the time the pap smear is indicated when there is suspicious condition and due to unprotected sexual activities, multi-partners sexual activities, they have more chance of, and you know that papillomavirus, okay, there are multiple papillomavirus, but there is a specific number papillomavirus can cause cervical cancers. Okay, so now when they take the tissue out, they will make the examination on the slide that has a cervical cells, and they will observe. They will like to categorize this class 1, class 2, class 3, class 4, class 5. Okay? If on the slide there is nothing change, cells are normal, they know the typical cells, they know, and they found the typical cells, so then we consider as a normal. That is normal cervix. And class 2, when there is a atypical cells but no neoplasms. That means if I draw the diagram, okay, so this is vagina, this is cervix. Okay, so they will insert the cotton tape through the vagina and they will touch on the cervix, and look, this is the fornix area, this is external os, and this is fornix area. They will take the all kind of cell secretions with the cotton tips. Okay, so this is cotton stick. Okay, so if they see there is no abnormal cells, so then it is class 1, that is normal. But when atypical cells but no neoplasm, the cells are atypical, that means when they will take the cells out from there, it looks little atypical, but not always the atypical cells it is a problem, but it is an early sign of cervical neoplasm. Okay, if there is the atypical cells, then the doctor will take it seriously. Okay, let me see some history from you. How is the family history? Anybody suffers from any cancer in the pelvic cavity, especially the cervical? Do you have unprotected biological activities? Do you have multi-partners? They will take the history. Then they will take the history. Are you suffering from any kind of herpes, genital herpes diseases? Okay, and at what age you become sexually active? Okay, so they will take a lot of history and they will say, okay, if all those are negative, so don't worry, we will have a follow-up every year. Sometimes, if it is indicated, every 6 months. Okay, so they don't want to miss anything. So we understood the normal, we understood the atypical cells are there, but there is no neoplasm. There is no neoplasm. So now, stage 3, it says dysplastic cells. What is this means? This means abnormal. Painful means away from normal. Plasia means growth. Away from normal, really not only atypical, is also undifferentiated. Okay, and there is a neoplasm. Okay, let me draw. Okay, let me use the different color. Okay, cervix looks like that. And when you found there's a dysplastic cells, then you need to understand that something is growing inside the cervix. Okay, and that is stage 3. Then what is stage 4? Okay, so this is 1, stage 1. Okay, and stage 1 plus 2. Now, stage 4, it says non-invasive carcinoma. Oh my God, what is that? There is a definite pathology. Okay, look at the cervix. Cervix has cancer, but it is non-invasive. What does that means? Non-invasive, okay. Non-invasive, usually it did not go away from the cervix. It is confined within the cervix. It invades into the 3 layers. There's a mucous layer and the muscular layer, and it reaches up to the perimetrium, but it did not go out of that. Okay, this type of cases, usually they need MRI or CT scan. MRI is better. Okay, so this is stage 4. Okay, and stage 5 is invasive carcinoma. Stage 5 says okay, if you see this type of pathologies, then you see there's a lot of lumpy bumpy, then you will see the lymph nodes are enlarged, and there's a heterogeneous area. Okay, and you see the cancer might spread into the vagina, into the pelvic cavity, into the uterus, fallopian tube, on the ovary, in the pelvic cavity, pelvic floor, pelvic wall, whatever it is. Then we consider it is a invasive type 5, and there's a cellular differentiation. The cytologists, they can figure it out. If it is a stage 4, it is a stage 5, what should be the involvement of the cancer cells within that area. Keep that in mind. Cancer cells invade through the tissue. Cancer cells invade through the vein, invade through the artery, invade through the lymphatics. Cancer cells will invade through the interstitial spaces and it will come out. Okay? So then we consider it as a stage 5. Okay? So that's the way the pap smear they will discuss. And when the pap smear is positive, so most of the time they will follow up. They will, if this type, they like to cut the they would like to do the radical uterine removal. Okay, so and hysterectomy, radical hysterectomy is indicated. Also, they will do the radiation, and if it is spreaded, then they will they will take the organ out, then they will do the chemotherapy. Okay, so now I'll discuss about the Culdoscopy and laparoscopy. Okay, Culdoscope. Culdoscope is insertion or inserting an instrument that has a magnifying glass like a microscope with light, and there's a cauterization in the tips, and there's a cutting scissor and surgical instrument applications, and it is connected with the monitor. They send picture on the monitor, you can see all those things. Then how? What is caldo? Caldo means the vaginal vault. Where is the vaginal vault? The vaginal vault is here. That is called fornixes. Okay? They will insert the instrument, either they will insert through here, okay, and this is the tip, and that has lights, then camera, cauterization, then cutting scissor, etc. It can go through the posterior fornix, it can go through the anterior fornix, and they can see the pelvic cavity, adnexal cavity. They can see outside of the uterus, they can see the ovary. Ovary is right here. You remember the ovary? Okay, this is ovary. Okay, and there's a fallopian tube right here. Okay, this is fallopian tube. They can see this is ovary, fallopian tube, and the broad ligament, and all other tissues in the pelvic floor. Okay, they can see. So direct visualization of the pelvic organ through the vault of the vagina, that is the fornixes. They cut and they insert the instrument, and the instrument tip goes in the pelvic cavity, and they watch everything. Okay, then what is the advantage? Advantage is they can see clearly, number one. They can better understand what is going on. If they need to separate something, they can. If something is need to be cut, because there is addition, band form, ligament, false ligament, there's a lot of addition, they can separate. But it is better done over the laparoscopic surgery. Okay, but this is Culdoscopy. Okay, so okay, this will be handle. Okay, this is a handle. They can do this. Okay, and now I will talk about the laparoscopy. What is laparoscopy? Nowadays, you know that laparoscopic surgery is very popular. In laparoscopic surgery,